So yeah, we were going through and kind of figuring out what you guys might want to hear about and trying to mind read, but we're not the best at that. But so we thought about, well, how have we been engaging primary care doctors that have been um, referring to us over the past several years, because especially with COVID and mental health, I think, has become just a center point of a lot of um, care. And I like that. Doesn't include mind reading. Maybe someday. Um, there's just a lot of patients out there, and we're just as flooded, and I'm sure you guys are just as flooded as we are, and what do we do, and how do we kind of expand resources and collaborate together, and hopefully get people better faster, but also maybe even keep people from getting sick in the first place. So you guys really are at the front lines, for when it comes to the care for any kind of patient. But in the mental health world, I'm pretty sure that SSRIs, I think the majority of SSRIs in the country are prescribed by PCPs. And so, you guys are clearly getting so much exposure to uh, to what's going on. So we thought about it, and we thought, okay, well, how can we come up with some objectives that are going to be helpful? And so we thought about kind of frontline mental health and first pass psychiatry, kind of like first pass metabolism. You know, you can do a lot in that portal circulation that maybe take the load off the kidneys or something. But so let's see. So we thought about how, uh, we've been blessed with the opportunity to treat a lot of treatment resistant depression just by the nature of operating a transcranial magnetic stimulation clinic, which is FDA approved for treatment resistant depression. Um, it typically has about 70% effectiveness when it's done kind of in the conventional format. And so we thought, gosh, well, how can we help the other 30%? And who is the other 30%? Was the big question that we keep trying to answer. How do we reduce how often somebody needs to do TMS? Insurance companies usually allow for it to, they'll reimburse every 6 months or so. So by their metrics, they're thinking, 6 months remission rate is good. But it's a 2-month journey, and um, it takes a lot out of someone's schedule. And if somebody needs it again, then have we really treated the root cause? Have we really helped them to the extent that we should be able to? And so, thinking about that 30% that wasn't responding, thinking about those who did respond, and symptoms went into remission, but then recurred later, we started to look at some of the differences between those who responded and those who didn't. And so that's where we kind of landed um, initially with this observation that people who had their sleep apnea treated tended to respond better with fewer side effects, responded more quickly to TMS, transcranial magnetic stimulation, and then had lower recurrence rates after they went into remission. And we thought, that's interesting. What's going on there? And so we started investigating sleep more, um, what good quality sleep means, learning more about breathing, learning more about circadian rhythms, and began kind of stratifying different levels of sleep problems and correlating them with different degrees of mental health symptom severity, whether it's anxiety, depression, um, and so OCD. So we started to kind of, draw these correlates, finding interesting papers in the literature that, we hadn't been exposed to in our specialty training, and started to realize that that part in the DSM that under, I think it's basically every single diagnosis, there is a criterion that's supposed to be met that other um, the medical rule outs have occurred, that we have ruled out medical etiologies for mental health symptoms. Um, and I think that criterion needs to be revised by psychiatrists, again and again, revised in the sense of revisited because medical um, conditions and the extent to which we can treat them, um, more specifically, that's expanding over time. As you guys, our colleagues, are pushing the needle forward there and what can be treated and to what extent it can be treated, these medical problems, it's getting better and better, right? Thanks to you guys. So we as psychiatrists, do a lot of revisiting, what you guys do. And it turns out that we were missing stuff. We were missing stuff for our patients when they come in sad and depressed and they tell us about their social situation. We can wax philosophical about all sorts of psychological reasons why that person's feeling junk, but sometimes it's because their car is not working well. So we use this metaphor of the car and the driver, where psychiatrists, we generally are, thought of as people who help people drive their car better, their physiology, how their brain's doing, how their heart's doing, how their medical conditions are doing or affecting them. Um, and the ride through life is really determined by, um, yeah, Kelly, what's up?
Thanks. No, I didn't want to interrupt you.
Oh,
You're on
sorry.
a roll. I love it when people are looking at what they're doing and then taking it a step further and saying, how can we actually prevent people from needing our help? I mean,
Yeah.
that is so
Mhm.
admirable. But I wanted to tell you some good feedback. Well, first, I want to tell you you're on speaker mode, so we're seeing the slides on the side. So I didn't
Oh,
know if you
oh,
wanted that. But
oh,
a couple of good chats came in, and one of them was like, "Was he reading our mind? Does brain health read our mind?" Because we were talking about this sleep and stuff. But the other chat um, is just so wonderful. Dr. Keifer's intervention saved my daughter from being a lifelong anorectic. Chloe is doing so well, Doc. And I
yeah.
just thought I had to get that to you. That's from Randy Dellinger. So we know you just don't do sleep all by itself. You do the whole thing. And I just really admire what you're doing. So anyway, yeah, your slides, and I don't know if you were advancing them or anything. We just see the slide 2 with objectives in the
Oh,
presenter mode.
yeah. Yeah. So we have these objectives and that's kind of the backstory of like how we've how we've been finding more medical rule outs, and trying to get those treated or start to treat them ourselves. And people have been getting better. And one thing that gets us excited and to go to work in the morning is finding out what else we're going to learn from our patients. What else do we not know, you know, and that's exciting. So developing an awareness of the impact of physiologic conditions, we're hoping that we can just kind of, it's more like, hey, yeah, these things that you guys thought affect people's psychiatric symptoms, they sure do. And that's what we see on our side too. And when we help patients to get those factors treated, things like major depressive disorder, generalized anxiety disorder, specific phobia for XYZ, anorexia nervosa, bulimia, binge purge, binge eating disorder. These things change. These downstream DSM diagnoses change dramatically when a lot of these conditions are treated. Identifying sleep disorders, their potential clinical relevance. How do we evaluate circadian rhythm disruption? Um, Interpreting apnea metrics. So one thing we discovered is that what we were taught in medical school um, does not about interpreting sleep studies. It doesn't fully capture. In fact, there's a lot of false negatives that occurs with the criterion that we were taught with regard to brain and neurological and psychiatric issues. And I think the reason for that, we'll get into it, but the nervous system is one of the few organs that's 100% oxygen dependent, and especially at a younger age, even more vulnerable to these changes. And the threshold for what is a sleep problem should be set lower because of the lack of myelination. Um, of the brain and of the nervous system for our young ones. Um, Assessing concussion and subconcussion history. Well, another thing that we've observed is that you don't have to have loss of consciousness after a head impact. You don't even have to hit your head on something. You can just have a whiplash injury in order to have lasting neuropsychiatric phenomena, you know. And so we have noticed that a lot of the patients that we see, their symptoms started after a non-loss of consciousness concussion that wasn't fully treated and unfortunately, didn't get better spontaneously. Um, and then developing awareness of the significance of long COVID symptoms. What do they look like? How are they a little bit different than standard depression or anxiety? How are they similar? And then ultimately enhancing patient outcomes through early intervention. And I think there's a lot of things that, we, yeah, man, it's wild. Even over the counter um, measures to help someone's breathing, sleep, and therefore their mental health outcomes, especially for mild to moderate cases of depression and anxiety, which is, the majority of what you guys, would be treating before referring out. And um, Kelly, should we stop for a second for questions or just kind of keep on rolling? What
I
we're
would keep
planning
on
is
going.
about four more slides
Yeah, I
before
haven't.
we get asked for examples. Actually, we would love to work a case openly with anybody who wants to present one, and for us to give our thoughts about things that we think about that we would take the next step to.
So I don't have any questions in the chat. Does anybody have any questions they want to ask right now? All right, go, 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 go.
Okay. All right. Do you want to talk about this part? Okay. Yeah. Um, so so patients with difficult to treat depression in primary care. Um, how do we rule out some of the resistance, revisiting the diagnosis, establishing adequate dose and compliance, and then addressing medical, psychiatric, and sleep comorbidities? Um, and then thinking about a little bit like when do we think about, okay, is this a little bit out of our league or is it not out of our league? If you address these medical, psychiatric, and sleep comorbidities and they're still depressed, thinking about, okay, I've tried 2 trials of antidepressant medications, um, and I've referred to a therapist. They've been getting CBT, and maybe we've done an augmentation strategy that I'll briefly review in a little bit. And maybe it's time to consider something like ketamine or brain stimulation, and who do I refer to for that? Um, so, so antidepressants, they're fantastic, but not often. Um, their response rates are actually pretty low, and having a couple augmenting strategies in your back pocket can go a really long way. Um, One of the best augmenting strategies is a DNRI, a dopamine and norepinephrine reuptake inhibitor, bupropion, which I think a lot of you are familiar with. And what some of you may not be as familiar with is what can we add bupropion to or Wellbutrin? And it's actually basically every SSRI. Maybe like a little clinical pearl would be adding bupropion to fluoxetine or Prozac can have a little bit of a higher load of norepinephrine. And so some people may tend to get a little bit more anxious or have some cardiac symptoms for you to be aware of. Um, but Wellbutrin on its own too is a great medication to start with, especially if it's the kind of depression where they have low energy. But as we're going to talk about later, if they have low energy and they're depressed, we should also be thinking about their sleep quality, right? Because that may be the medical etiology that is either creating or at the very least perpetuating their depression. SNRIs, venlafaxine, desvenlafaxine, also known as Pristiq, and duloxetine, Cymbalta. These are great strategies. One tough thing about it is that you have to cross titrate from your SSRI. And so that can be a little bit trickier to manage. usually coming off of the SSRI, a half of the total dose per week or per 2 weeks, depending on tolerance. That's a nice thing to write down. Is a decent taper schedule if they haven't been on it for, you know, over 6 months or a year. Um, Now there's the, the duloxetine. It's an older strategy, but if you're on Lexapro, which has very little norepinephrine effect, you can co-prescribe Lexapro, also known as escitalopram, with duloxetine. Um, some people may already be on Cymbalta. I think yeah, you guys are. I've seen a lot of primary care docs start Cymbalta, especially if there's comorbid joint pain or fibromyalgia. If that patient that you started Cymbalta for then becomes depressed, a good strategy can actually be to add Lexapro. So start low, go slow. As my old supervisor says, don't forget to go. Um, so um, So starting Lexapro at whatever dose duloxetine that patient is on, around 5 mg. Um, but be careful above 10 mg. At that point, you might want to send them to a psychiatrist. But that oftentimes does the trick. Mirtazapine is a good one. You get a little hungrier, you get a little sleepier. And that one's nice because it can be added to any of these medications, any SSRI, Wellbutrin, any SNRI. The other four, just kind of putting them there, you may not be comfortable with prescribing these, but just to let you know, these are some of the other augmenting strategies that psychiatrists use. Buspirone is actually, I'd put that as another back pocket that you would use. Buspirone, just think buspirone, anxiety, anxiety, buspirone, buspirone, anxiety. And it can also be added to most of the other typical antidepressants and atypicals. So generally after an SSRI fails, these are some of the options that we would do. And intolerability, of course, is something to look out for, in which case you would switch the medication. So that's the boilerplate next step, kind of in a nutshell for you guys when it comes to medication management. Um, but some of the really rewarding observations that we've been, I guess I would say, shown by our patients and their conditions. Like I said, born out of our observations from treating treatment-resistant depression, um, come back to sleep quality, breathing quality, concussions, long COVID. There are other ones, but man, I don't know, 90% kind of gets covered by these five.
I would say easily.
Yeah,
Yeah.
yeah,
Yeah.
yeah. About 90%, I'd say, of the treatment-resistant cases, when we screen for and subsequently treat any combination of these five that are up here right now, that 70% number. So remember, conventional transcranial magnetic stimulation for treatment-resistant depression treats symptom remission in about 70% of patients. So that 70% plus treating these five on the screen now gets us at 90% or more, is what we've been observing. So I do want to pause for a moment and see if anybody has a question before moving on to this phase, because it'll be this and then any examples or any cases that you guys are kind of wondering about, maybe the long list for the psychiatrist, maybe the patient or family that you're working with has a stigma against starting medications or doing therapy and you're trying to help anyway, and or they're just really complicated or hard to treat. So we'll talk about this part, but anything, guys, maybe in the chat.
So Randy says 90%. That's impressive. And Renita says, what do you think the 10% needs? And Colton has a case. So
So, yeah, yeah, 90%, it's impressive, but it's really it's about, I guess digging in a little bit. I mean, we're fortunate as psychiatrists. I count my blessings every day that we get paid to spend time with patients, and so we get to ask a lot of questions. We usually see patients for at least 30 minutes for a follow-up. Initial appointment, we do an hour and a half, sometimes longer. Um, and um, and so we've come to ask a lot of questions that maybe aren't normally asked, and just trying to figure out like why is it that this is problematic. And um, but I think it's also just a little bit of a gap in the threshold for what is considered a
Mm.
problem. Um, and I think our Western medical training is really good at teaching us how to treat acute problems. But these neuropsychiatric brain problems, they're really acute. Maybe the one related to concussion, long COVID, but they come cloaked in a diagnosis of like depression and anxiety that's really more of a chronic problem. And finding the causes of a chronic problem is kind of challenging. It's not in your face. And oftentimes it's the slow grind of something like sleep apnea that just hides itself at this subthreshold subclinical level, and like this idea of like subclinical hypothyroidism that we've all been exposed to. That slow grind with time can create the problem that then comes into our office. And so once we started to think about it like that, and we started wondering, okay, what are some other things that people are faced with, our physiologies are faced with, that can can be a part of that slow grind? Um,
Yeah,
then
it's really like thinking of this, you kind of put it all in one slide here, but it really was a point of, 5, 6, 7 years ago of thinking about these things that would ordinarily be just sort of like symptom or history checklists. And then we actually started finding ways of creating data markers to measure each of these things. And as many, if not all, of the people or patients that we're interacting with, whether we were assessing and or treating them. And then once we started quantifying that, allowed us to identify some of the subtleties that, quite frankly, previously, if I saw an AHI of 4.9 or 5.1, that I would, the former self would say, oh, that's no big deal. It's a mild problem. But then after ruling out all these other things that were creating somewhat of a treatment resistance, if you will, and then beginning to address these variables that historically we would look at it like it was nothing or small, and then beginning to see the results. I think that was the main thing, is beginning to see people's mental health and brain function improve over time on average as we started to evaluate. Like one of the things we talk about around here in terms of sleep disorder breathing, one is that, well, pretty much everybody who snores has apnea, but not everybody who has apnea snores. And then we think of, we really don't like to talk about mild, moderate, or severe, because we feel like many of the people we see, when they hear the word mild, they just kind of turn away as if it's not a big deal. And our observation and measurement of data in the last 6, 7 years, I mean, it's like you can have mild, moderate, or severe brain cancer. Which one do you want? It's a slow growing brain and body cancer, but it's wearing the system down. And so beginning to look at, the AHIs that are 4.9, 5.0, 5.1. Unfortunately, I believe Medicare still adheres to the 4% criteria. We find that the ASAM criteria, if for lack of a better way of describing it, is just more consistent with how we see these breathing and sleep issues impacting the central nervous system, the brain
And
function, and then downstream.
ASAM is says American
Society
Society of
of Sleep Medicine.
Sleep
Yeah,
Medicine.
so I forget when that was. It must have been about 5 to 10 years ago. They reclassified, and now
Oh yeah, it's supposed to be AASM.
is it
Sorry,
A? Sorry,
AASM.
sorry.
Yeah,
I was trying to figure it out.
not
Thank
not
you.
not addiction medicine.
I'm mildly dyslexic. The
Um,
so the the percentage of hypoxemia and what's required to meet the threshold. I mean, these are big deals. Like you'll see some people who, if you use the 4% criteria, will look like they have 0 events, but if you use 3% criteria, they have anywhere from 5 to 10 events per hour. So that's a pretty big difference when you're thinking about the potential impact of fragmented sleep and intermittent hypoxemia during a time when the central nervous system is supposed to be resting and kind of taking care of itself. It's being distracted, fragmented, and stressed. So as we've dug into these things, we've seen some cases when we're lucky, sometimes we can just start to dig into those things and people will over time get better. We looked beyond just the history taking of sleep and really started to think about, okay, it's not just sleep quantity, right? I mean, and I think part of it is we're fortunate to be child, adolescent, and adult psychiatrists. So it's our ability to be exposed to, observe, and work with the human condition throughout the life cycle. You really get a real firm, for the pediatricians that are out there, you kind of get, you get a firm observational grounded experience of like, well, okay, what happens to these developing brains when they only get 8 hours of sleep versus when they get what they're supposed to get 10 to 12. And even if they get 12, what happens if they go to bed at 7 p.m. versus if they go to bed at 7 p.m. and wake up at 7 a.m. or if they go to bed at 12 midnight and wake up at 12 noon. Well, those are two different things, because as we begin to sort of dig into it, there's a lot in the last 5 years about circadian rhythm and sleep windows, and knowing that the time at which you go to bed and the sleep breathing quality have a lot to do, and arguably maybe more to do with the overall brain and mental health than the total number of hours you're actually asleep. You might add something about the nasal breathing.
But that does make sense. I mean, sleep's something we have to do every night. So when you say, would you rather have mild, moderate, or severe brain cancer, that's kind of, I mean, it will grow, but I can see how the night after night of sleep deprivation can really build up. I remember I used to take naps every weekend.
Yeah.
You can't really catch up, though.
We find ourselves talking to patients about it like, these mild, right, if you will. The AHI or RDI number of 5 or greater, these are benchmarks. It says nothing about the clinical significance. So it's like treating the patient, not the number. But also, like to your point, it's like you can park your car at the beach park one night, probably gonna be okay. But if you leave that same car at Ala Beach Park for the harbor every night for the next 2 or 3 years, well, you're going to end up with an electrical problem, an engine problem. The brakes aren't going to work. There's going to be rust all over. So you got to start having multi-system breakdown. And in many respects, I think that's largely what we've observed over time is we're seeing sort of the downstream breakdown, whether it's cause or contribution, that people really have a hard time responding to potentially effective treatments if these things are either under-investigated or under-treated.
We do have a question about shift workers, third shift, people who work overnight.
Oh, ooh.
Oh, don't do it.
We want the politically correct answer, or
no, just tell us.
Yeah, I mean, it's absolutely devastating.
There's no way around it. There's no way around it.
Those are some of because so a lot of the things that Dr. Shipley and I are covering are really truthfully born out of the first couple of years of doing neurostimulation and just wanting to see the best results and trying to figure it out. And I'll tell you that our night shift workers have some of the lowest response rates, and that's when we just kept, okay, is it because of this? Is it because of this? Is it what I understand, we want to be sensitive. Obviously, jobs are not easy to find, and good ones, and many of them are well paying. So it's trying to thread the needle with the patient to try to help them. In the end, that's a significant current moving in the opposite direction, because mostly because of the the sleep window or the timing of sleep, the bulk of our sleep needs to occur from around 9:30 p.m. to around 5 a.m. And once we start challenging a few thousand years, I think probably of evolution, those are those are hard systems to beat when you start looking at the circadian clock, light exposure, and sleep quality, and all the neurohormonal rhythms that are at play.
Yeah, and I mean we just even if we treat their apnea, um, they don't get the same response rates. We measure the electrical activity with structural EEG for all of our patients, and you'll just see a significant reduction in the power um, in the awake state that that brain is emitting. Um, and so, yeah, it's tough. Those are tough cases,
What
and
about if
mhm.
can somebody adjust their own cycle like over years? Like Ella says she was a night worker and she's a night person and she was on that schedule even on her days off. I mean, it sounds like it's better. I was talking to a hospitalist this weekend. I'm trying to recruit uh, doctors to Hawaii, and she said, "Oh, I do the hospitalist. It's okay at night. You do a week on, a week off." And I thought, "Oh, that's really hard." But here's Ella who worked years with the night shift and just kind of adjusted her own rhythm to it, I guess. Do you have
Yeah, I
anybody
mean,
like?
there's I think there's a growing body of work around chronotypes. Um, is that and the question for us then becomes as clinicians, is something that seems to work out for a handful of people. Um, should we draw clinical generalizations for our patients based on that? And so, um, the night shift workers, it's not that they don't get better at all, but the response to treatment appears to be lower. And maybe it's a difference in a lot of other conditions in that person's life that supports that lifestyle. But
And
but
and
generally speaking,
and also tracking, not just that, your own or your patients or whoever it is, and not just the symptoms, right? Being honest, am I potentially having symptoms? Because that's really, like Eric's saying, like there are chronotypes. It's a very small percentage of human beings on the planet, by the way, but they exist where there are altered circadian windows. Um, but essentially, having thorough medical workups and evaluations, and really being in tune with, am I actually being impacted by this, can help with making that decision, right? Because you can have sleep and circadian rhythm disruption and increasing risk for hypertension, diabetes, eye problems, cognitive problems, mental health issues, and any number of things that are perhaps easily quantifiable. And if you do have patients, or it's you who works a night shift or has an altered sleep schedule, get a good baseline and track it, you know,
mhm.
because if it's not consistent with your kind of genetic subtype, if you will, then ultimately over time, symptoms or dysfunction will arrive in one way or another, and that may help sort of sift through it. But if you worked for years on night shift and you're no longer on night shift, I mean, you're having a hard time resetting. Um, the first thing I think, if correct me if I'm wrong, the first thing I would want to know is like, what does your sleep study look like now? Because that may be a barrier in terms of you just naturally resetting if you're no longer working on night shift. Is that there may be a low level sleep breathing disorder that is impacting your ability to sort of settle into a more healthier rhythm.
Well, I've got two questions and a case. So this is very exciting. Um, the first question is a stupid question. It's mine. I heard an advertisement for a sleep apnea machine that you don't have to put a mask on. I figured it was a hoax. They just wanted money. But have you guys heard of anything like that?
Yeah, are you talking about these nasal inserts that produce like a fan, the micro fans that push? Is this the one?
I don't know, but that sounds good to me.
Yeah, I mean, there's a coming wave. I was speaking with a company a couple years ago. I don't know that they've mastered the micro technologies to produce enough of an airflow. I think that maybe sometime in the future there may be something like that that will work. But right now, like I ordered a few, and I we were able to get one of the companies who goes to send it and kind of tried it, and I don't think it's able to produce sufficient inspiratory pressure yet.
So maybe in time.
Yeah, I mean, with
All right.
technology advancement, it maybe won't even take a year or two, because I know there's a there's a there's a huge demand for it, and there's a lot of really smart people in Silicon Valley that think in terms of nanotechnologies, and so I wouldn't be surprised if they were able to develop something in the next few years.
That's exciting. Okay, I have a question from Ricky, and it's two-part, but it's all about the same thing. Um, I think I speak for the group when I say we love how you're looking at the rule out rather than just assuming things and all the things you're doing. But what if the patients can't get the rule out work done? What if prior authorizations limit the labs or the workup that can be
Mhm.
done? What if people cannot get to medical appointments for the rule out workups? Do you guys have a workaround for prior auths
Do
or
you do
limited?
you I mean, can someone give us some more information on
What kind of
what are
limitations
the
that you guys,
limitations?
some barriers you run into with regards to what's up
Okay,
on
let's see. What would you order on someone who, well, okay, let's say they can't do the sleep study. Let's say their insurance doesn't
Sure.
cover the sleep study, or they have little kids, single mom, and they can't go to
Mm.
stay. Well, they could do a home sleep study, but those aren't as good.
Yeah, so this is yeah, this kind of brings us to something that I've been excited to share. And what we so first of all, totally get it. It is challenging to get a sleep study. You know, we've we've gone through the process of um of being able to send people home with sleep studies from our clinic, but again, depending on their insurance.
Mhm.
And then we've also gone through the process of identifying sleep labs on Oahu that do take other, like Quest Insurance, for example, Medicare, and it's been hard.
Mhm.
So we've been trying to streamline that as much as possible. I think just the quantity that we've been doing it. So, like Kuakini does technically, we send non-commercial health insurances to Kuakini. The caveat, though, is that they use a belt study, and a belt study is different than some of the other newer home sleep studies, and it tends to have, in our opinion, a lot of false negatives when we go and give a lot of those patients a sleep study um, that we believe to be more accurate, more specific, more sensitive. Um, we find that there was a lot that was not counted, a lot of events per hour. So yeah, it is challenging. Um, there's some workarounds, and maybe we can have another session about that. Um, but exciting part is there's actually a lot of over-the-counter methods to help people. Um, the power of the breathe right strip, I call it Dr. Long's for a lot of patients. Like, you got to go to Dr. Long's, guys, because Dr. Long's actually has, with the right combination, some powerful ways to help you sleep better tonight. I've literally taken people off of Seroquel with Dr. Long's.
Mm.
Um, and so a breathe right strip. So the combo would be a breathe right strip, Flonase, one spray each nostril twice a day, morning and night, and Zyrtec. And that trio can do some massive work for somebody.
Mhm.
Very surprising how good, especially if they have a little bit of anxiety, because anxiety lives in the nose. It lives in the nose, man. The thinner and harder it is to breathe through your nose, the more dysregulated your autonomic nervous system will be. And there's some neat studies that have been out in Nature now that have done studies of unilateral yogi breathing. If you breathe only through your right nostril, you're going to activate your sympathetic nervous system. Only through the left nostril, parasympathetic nervous system. Humans have observed this for a long time, and now science is showing it. That works for people that can actually breathe through their nostrils well. A lot of our patients cannot. And so if you help them, and this is something we love to do in our initial appointments, in the appointment, as we're helping our patients to observe for themselves, and it's part of our diagnostic workup, how well they can or cannot breathe through their nose. And for the patients that come through our office, about 75% of them or more can't breathe well through their nose. And so when we put a breathe right strip on their nose, I mean, probably once a week we hear, does everyone breathe like this? Some people literally will cry because it's just so relieving for them. Migraines and headaches will go away during the session, and just remarkable things happen. And the easiest way to think about it, guys, is, brain problems are engine problems, and engines can have problems depending on the housing that it's in. So the nose has a lot of functions, nasal breathing has a lot of functions. And there's probably a whole nother series that there's about 5 more lectures that we
No,
could do on
no,
nasal
we're
breathing alone.
inviting you back, and we're
But
talking about
Yeah,
Dr.
I certainly
like,
think it was,
yeah,
this was the evolution of looking at sleep and then seeing the results and then looking at, I guess, the different phenotypes that we eventually come to see that are driving the sleep issues. And the thing that Dr. Shipley's pointing out cannot underscore enough, and maybe it's not everyone, but there's a significant number, likely if you're in primary care, that have some form of a nasal flow issue that can cause or contribute to the ongoing anxiety, mood issues that are problematic. And simple things like over-the-counter nasal dilator, breathe right strip, Flonase, Zyrtec, in some cases can really make a very big difference in that person's quality of life within a matter of days to weeks. And so that's kind of like potentially in a primary care setting, like a low-hanging fruit. Like we actually have all of these things here in our clinic, like cabinets full. And as part of our assessment, we'll frequently use them just to see. We have some ways of measuring it as well, but we'll get subjective and objective responses to it as a way of hopefully getting the ball rolling for them sooner rather than later.
Okay, well, let me give you the case, and then we have a question about traumatic brain
TBI.
injury as well. But
Sure.
short case, 45-year-old with depression, anxiety with panic attacks, social anxiety, moderate OCD measured by YBOCS positive, tried and failed fluoxetine, got rapid weight gain, duloxetine, excessive fatigue, Lexapro was ineffective, refuses to take anything else, not taking anything right now, has been in psychotherapy for a couple of years with a licensed LMFT, including cognitive behavioral therapy. She has fibromyalgia. She hasn't worked for over 5 years. She tried to get SSDI but couldn't. She lives on the same property as her parents, but in a separate unit. So she's not on anything for any of the depression, anxiety, the OCD right now. What would you recommend as some alternative options, because she doesn't want any medications because of the prior side effects?
Well, so things that really ring out is that OCD part. And I think that's a big rate limiting step. OCD, the more we encounter it and kind of think about it, the more we realize it's kind of it's like the fabric of someone's cognitive ability to engage with the world. Your ability to let go of thoughts is down. That's why it's an orbital frontal cortex problem, oftentimes comorbid with ADHD. And um, and OCD, it also, it's something that if you look at the anatomy of it, the neuroanatomy of it, the three main regions that are involved with OCD are all along the midline, and they actually are just adjacent to the nose. And I haven't seen a single case of OCD that doesn't have a nasal breathing problem based on the metrics that we use to identify that. Um, and usually also has a degree of inflammation in the nose. So breathing problems in the nose can be related to a skeletal structural defect, plus minus, usually plus a mucosal inflammatory defect. And so these are the two ways: the tunnel's smaller and the insulation's bigger, and you have problems with nasal breathing. Um, the relationship is the cribriform plate, by the way. If you look at that, that's where how our brain inserts its roots into the nose. And that's actually one of the first relationships that's created when you're 7 weeks old in your mom. You're mostly a front brain and an upper part of the nose, not the lower, and everything else starts to build from that. So I'm already thinking about how this person's nasal quality is compromised. I'm thinking about how they're living in some part of her parents' house or his or her house, probably isolated in the dark a lot. It's Hawaii. That means that you might be around a lot of allergens, plants that are growing right outside. Um, you're depressed. That means you're not going out a lot. That means you're not getting much sun. I'm thinking about vitamin D deficiency. I'm thinking about how allergies are untreated. I'm thinking about how she probably at this point also has full-blown apnea, not just a nasal breathing issue. And for her path out of this condition is definitely going to need some of these rule outs to be investigated. Um, Medications could help. Let's say that she were to be on board, just so that we cover that. Luvox or fluvoxamine is typically, I observe it to be much more powerful for specifically OCD, but not for depression. But I think if you treat the OCD, I think a lot of the depression and anxiety can get better. Um, and then in conjunction with fluvoxamine, you can also prescribe risperidone. For somebody who doesn't want to do medications, they're probably definitely not going to want to do an antipsychotic. But Luvox is generally better tolerated than the other SSRIs. Risperidone, actually, in the short term, generally pretty well tolerated. The long-term consequences of prolonged antipsychotic use, you know, Parkinsonism and metabolic syndrome, those don't happen until a way later. So they can be, we still use them in the acute phase when we're trying to get somebody out of their hole. Once they're out of their hole, then we got to find ways to peel it off, of course. So to the physiological, again, the nasal breathing. If she's willing to at least treat her allergies, willing to begin to use a breathe right strip at night, potentially, you kind of need to do a physical exam to see if they can tolerate mouth taping. But first, you want to open up their nose is the big thing. Open up their nose and then consider mouth taping to make sure that they're breathing through the nose and activating the brain in that way. Then get them outside, get their circadian rhythm um, corrected, because I've probably like 5% chance that she has a normal circadian rhythm. I mean, any of us, I know for myself, when I was, you go to spring break and then boom, uh, or some kind of break and your circadian rhythm goes upside down. So she's not working. She's socially disconnected. Her social rhythms are off. Circadian rhythms are probably definitely off. But if she can do the trio from Dr. Long's and she can start to go on a morning walk during the first couple hours at sunrise and after, um, you got a chance at beginning to break the ice of some major underlying physiologically driven aspects of those three conditions. OCD, anxiety, and depression, but particularly OCD. Um, and yeah, and if she's open to it,
Tell me, Dr. Long, again, breathe right strip with
breathe right strip,
Flonase.
Flonase, and Zyrtec.
And
And
maybe a Neomed sinus rinse morning and night.
Say
yes,
that again.
the Quattro. Neilmed, Neil, Neilmed, and sinus rinse. Yeah, and Neil med sinus rinse.
Well, we're going to have to invite you back because this has been wonderful.
Yeah, it's been a pleasure, guys. Thanks for having
Yeah.
us.
So you guys just pick a Tuesday later in the year and we'll have you back because we didn't even get to answer all the questions that people had. So,
Yeah.
all right.
All
Thank
right.
you so much,
Thank you for
gentlemen.
Yeah.
having us.
Thanks, everyone. Yeah.
Yeah.
Good to see you all.